Hello and welcome to the Doc Podcast. I'm your host, Dr. Mike DeLuke, and it's my mission to help you lead a happier, healthier, and more prosperous life, both personally and professionally. Hey everybody, it's Dr. Mike. Before we begin today's show, I want to extend a sincere thanks to my audience. It's hard to believe, but as of the air date of this episode, it'll have been a year since I started the Doc Podcast in mid-2023. When I started the show, I honestly didn't know what would become of it. I had no experience in the podcast arena, but I had a real passion and vision for what I wanted to try to do, and that was help my colleagues grow personally and professionally. And it's actually expanded even beyond that as I put content in that is helping people who aren't even in the dental or medical profession. And I'm starting to realize that we can maybe start to do more of that as well and just help people in general educate and inform for helping people's quality of life. I honestly never thought it would grow as much in this first year as it has. I hoped that it would, but my first guest, my good friend and colleague, Dr. Jeff Rothenberg, was kind enough to come on the show for the first guest episode. And we had a great talk. And after that, he was very encouraging and thought I had a future in this. And my wife as well has believed from the beginning. It was her idea that I go in this podcast arena. So I want to thank her as well. I just can't tell you how much I appreciate all the feedback and the kind words and the encouragement that I've received from everybody. I also want to extend a sincere thank you to all the guests who have appeared on my show over this first year. It wouldn't be possible without each and every one of you. And thank you for giving me your time and giving myself and this audience your time, your knowledge, your enthusiasm, your passion. And I really can't express just how much I appreciate all you have done. Going forward, I look forward to another awesome year and many years after that. I encourage everybody, keep downloading and sharing the show with others. Be sure to subscribe to my YouTube channel. I can put a link to that in the show notes for today's show. And if you feel we've earned it, we'd love to receive a 5-star rating on Apple or Spotify if you could do that as well. By doing those things, it helps the show continue to grow and allows us continue to get great guests and continue to be a presence in this arena. Also, if you may want to be on the show and have something you want to contribute or know of someone who would like to be on an episode of the show, please email me directly at drmike@theorthocoach.com. And I will also put a link to that in the show notes for today's episode. So thanks again so much for all your support and enjoy today's episode. Hello, everyone, and thank you for tuning in to this episode of the Doc Podcast. I am really excited about my conversation with today's guest, Dr. Ben Miraglia. Ben graduated from SUNY Buffalo School of Dental Medicine and has practiced in Mount Kisco, New York since 1994. In his practice, he performs a good deal of interceptive orthodontic treatment, focusing on early childhood growth and development, and he also lectures nationally on this topic. Dr. Miraglia is the VP of GP Clinical Education with Candid Pro. He is the Chief Clinical Officer at Airway Health Solutions. He's on the board of directors of the American Academy of Physiological Medicine and Dentistry, and he is also a founding member and Chief Clinical Officer at Toothpillow. Ben is a wealth of knowledge in the area of sleep disordered breathing and the role that early orthodontic treatment can play in improving nasal breathing, and I am really excited to dig deeper into these topics with Ben today. So with that, I would like to extend a sincere welcome to Dr. Ben Miraglia. Welcome to the Doc Podcast, Ben.
Oh, yeah. Thanks for having me. It's my pleasure. These are my favorite things to talk about. I'm really excited to join you on your podcast. And again, I can't thank you enough for having me.
Oh, my pleasure. And just a bit of background into kind of your name is a name that has been coming up to me for years, well before I started the podcast teaching educational platform that I'm in now. I believe it was my Invisalign rep probably over a decade ago who knew I was doing a lot of early expansion and growth and development and ICAD analysis. And he's like, yeah, there's this other guy. And I was in upstate New York, a little further upstate than you at the time. And he said, there's this guy, Dr. Miraglia, and you guys are kind of similar. Like, you really talk when you talk, you say a lot of the same things and you should really meet. And busy practitioner. You just kind of, my head was down and didn't really reach out to as many people. And then I happened to be talking to a family friend whose dad went to dental school with my grandfather many, many years ago. And we were talking about something unrelated. And he mentioned you. And he's like, have you ever met, as I was telling him of some of the airway stuff I do, he's like, have you ever met this guy, Dr. Ben Miraglia? And I'm like, wait, like I've got to meet this guy. So then I said to Peter, Zagarelli, I said, Peter, please like introduce me. Cause at this point I've got to talk to him. And then we hopped on a call and just loved kind of geeking out with you on the ortho stuff and the airway stuff and the science of this stuff. And you're just a wealth of knowledge in this arena, and been doing it for a long time, not just somebody who, kind of this is your theory and you're trying some new things, but you were well ahead of the curve on a lot of this. You were ahead of me in practice. I've let it be known many times that when I came out, I was trained at UConn, amazing program, but we didn't talk about early treatment. We didn't talk about airway. So, I mean, I was a little later adopter in my clinical years of this, and you saw it early. So how did that happen? Tell me a little, like, what was your journey like? How did you even realize that this was a thing and start to dedicate your practice time to it?
Yeah. So in 94, I got out of dental school and I did a 10-year run doing crown and bridge and implant reconstructive dentistry. And so in Mount Kisco, New York, I was cranking with all of this fixed, beautiful dentistry we were doing and rehabbing the mouth, in adults. Mm-hmm. But because we were a family care practice, we were sending the kids out as a referral to ortho. Mm-hmm. And so, basically it was 11 years old. So 11 years old, you send the kids to the ortho. And then for 10 years that I'm doing restorative dentistry, I'm watching the results coming back. Because in a big practice that we had with two partners, we're sending like 30 kids a month. So wow. 30 kids a month are going, and they're going to like primarily one office and a backup second, but the office supposedly, right? And sure enough, on a cycle, then they're in the office every 6 months because they're getting their teeth cleaned. We're maintaining these kids. So I'm seeing in private practice for a good 8-year run of these process and results of braces from 11 to 15 roughly, right? And I'm watching it, and I gotta say, honestly, I'm looking at it, I'm disappointed. So I'm seeing this and I'm going, yikes. I mean, it doesn't look amazing. It doesn't look special. And you're watching this and you're thinking occlusion. Well, the teeth aren't meeting right. You're thinking there are spaces some places. There's some crowding that couldn't get resolved. The arches are always narrow. It seems like it's a struggle. They're fighting with rubber bands. You're getting asked to equilibrate because they can't seem to get a bite together. So cutting the teeth seemed like wrong, like just gut instinct. Like, I don't know, it's a 12, 14-year-old. Why am I cutting the teeth to make this match? Like, didn't feel good. You're getting the request to make a night guard. But how is that possible? It's a 14-year-old, 15-year-old. We've had the kid in the practice since they're like 5. And I'm looking at this kid, I'm going, I can't make a night guard for a 14-year-old. It doesn't seem right. I didn't think this is a thing. And then the TMJ problems, you're noticing a lot of kids are complaining of clicking and TMD, like symptoms, jaw pain and symptoms, but they've been my patient for 6 or 8 years before I sent them. Like, we don't have any history of this. We don't have there is no jaw pain or click or problem. Now you get your braces, you have these problems, and not even knowing what's going on. I was just disappointed. So I'm watching this and I'm thinking to myself, I just don't see this as being successful right now. You're challenging, you're having conversations, you're challenging, you're trying to talk through stuff. And the last straw for me was the extraction rate. Because I'm sending kids over there and again, I went to dental school for 4 years and I'm practicing as a restorative general dentist. I don't have ortho training. I got 15 minutes in dental school,
right. Like the rest of us, right? Means.
Yeah. You know what I got in dental school. I don't even know what. So I don't know what I know I'm not happy about what I'm looking at. And so sure enough, the extractions, and you're trying to talk it through and say, is it really necessary? Because I'm looking at these kids and I'm going, I don't even see severe crowding. And yet they're coming back being told, you got to take out the 4 bicuspids. Do you want to do it? Or we send it to the surgeon? I'm like, where's the crowding to warrant this? And again, it always came back to, they have reasons and there's a ceph and a tracing and a thing. And, it adds up to extracting the teeth. And I'm like, they're not that crowded. I mean, I was starting to feel like, I feel like this kid would be better off with nothing than extracting.
Interesting.
I don't see a severe malocclusion here. I see a mild malocclusion. I see a little bit of crowding, but to take out the 4 teeth, I'm thinking that's got to be worse than what they have.
Right. That's 15 millimeters an arch at that point.
So yeah, space. So, with the zero knowledge I have, big zero knowledge I have, I'm just gut instinct thinking this doesn't feel good. It doesn't feel good. And I'm feeling responsible because, here I am sending them for this, and then they're coming back.
Yeah.
And if I don't like it, I'm like, damn, I'm to blame. Like,
Yep.
I feel like it's my fault. Now I feel like it's my fault. And, we grow up in our Italian culture heritage. There's guilt, a lot of guilt.
Yeah.
And so, yeah, you grow up with heavy guilt load.
Yep.
So guilt is very powerful, and I'm feeling guilty. Now I'm feeling guilty, like, geez, I kind of steered them towards this, and I don't like what I see.
Hmm.
And then, anyway, the conversations led to arguments. And the
With the
argument,
practice, with the orthodontist.
yes, talking with the specialist became, more argumentative. And,
Okay.
what happens then is basically I got so uncomfortable and unhappy and displeased. I said, fine, I'll do it myself.
Hmm.
And sure enough, when you come to that, fine, I'll do it myself as a knee-jerk reaction, one moment I'm like, what did I just do? Because now I feel like, okay, I got to help these kids a different way. So immediately I started taking orthodontic courses for general dentists. However, I specifically sought out expansion early treatment. Let me get into something different. I knew there was no reason to learn what they're doing because I don't want to repeat that.
Yep.
So I'm doing common sense and logic in my head. I'm going, listen, if what they're doing between 11 and 14 is what I'm looking at, I don't need to be trained how to do that.
Yep.
So what's the opposite of that? What's the opposite of that? Because I want to learn something different. Well, 11 to 14 isn't working for me. I don't want to learn how to do that. I want to learn something different, early treatment, start research. So I found a United States Dental Institute out of Tennessee.
Okay.
And early on, and this is back, the early 2000s, I took some courses from them, and they had both GP and orthodontic instructors. So I had orthodontists and GP mentors there. And they started teaching me early intervention, and there were opportunities from the age of 3 on with different techniques and appliances, whether they were guides, whether they were expanders, whether they were fixed or removable, but everything was geared towards early. And the approach was, let's work on the foundation early. And at the time, they weren't exclusively non-extraction, but they were, if we work earlier, we have a better opportunity to avoid extraction. We'd like to avoid the extraction. So they were teaching about a very low rate of extraction need. And I loved it because, okay, I'm not going to do any extraction. I'm going to do the best I can. I took their courses. I went through a couple of years of their program. I started teaching for them. I became an instructor. And right away, I started treating cases earlier with a variety of tools. And sure enough, I was learning on the drive with these mentors who were helping me with the cases. And one case to the next, it turned out the earlier I intervened, the better it was for the child. And then you start working your way down. So I kind of began in the 8 to 12 range.
Yep.
8 to 12 was my beginning. They were like, hey, expanders work great here. Use the blah, blah, blah. Then I started getting then 7, then 6, then 5, and you're working your way down. And then you realize, hey, I can work 3 to 5. There are appliances that are built for 3 to 5. Let's get in there. So my early beginnings were about treating early, and it was about jaw development. It really didn't have anything to do with sleeping and breathing. So that's, 21 years ago.
Same
that's
with
very,
me. Yep.
because,
Very interesting.
when you're 2002, 3, 4, when you're taking the education and you're starting at that point in time, I don't remember even recalling anybody talking about airway, sleeping, breathing in 2002, 3, or 4. So that's real early days. Now, fast forward as time
has kind of fallen out of favor. As we talked about, the literature before that, they were, Ricketts in the 70s and going back to, early 1900s with Engel and then Bogue. And I mean, these guys knew Holzman in 1929, I believe it was. They understood it, but it was like our profession, our entire profession, ortho and general, we all almost kind of, something happened in the mid 80s ish. And I've really looked at the literature for this, but it was like mid 80s ish to, or early mid 80s into like the 2000 area. And there were a lot of articles that came out from some big thought leaders in the orthodontic arena that really put some heavy weight on the scale, opposing to shift that balance, opposing early treatment at all, like really devaluing it. I've used his name many times, and I don't, he's passed now, and he was a brilliant guy, but Tony Gianelli was just so against going in early treatment. Orthodontic had a bunch of articles, or had an article in the 90s just calling anybody who does early treatment a quack. I mean, you put that in the AJODO from someone who is really well known and prominent in the profession, and I think that's going to scare some people.
Carries a lot of weight. It does carry a lot of weight.
Yeah, you start to worry, is there liability here if I do this? So I think that's part of what I think. That's again, this is totally just me.
Set the culture. It set the culture for, we start at 11. Like it was
Yeah.
a
Yeah.
lot of that
Right.
research
Yeah.
set the culture for, we do this from 11 to
Yep.
whatever, 14. It's 11 is the starting age for this. And I'm familiar with some of that research. A lot of that research was based on doing early treatment and showing that it would all relapse anyway.
Yeah.
You probably know the authors and titles of these journals. I know they exist because
Yep.
generally you have an overwhelming load of early treatment showing that it's unsuccessful because when you remove things, because you can't put the kid in something at 8 and hold it till 12,
Yep.
you do your work. So you've made some expansion, you
Yep.
take it away. And when you track those kids, they go back to the starting point. There's a full relapse. And the conclusions were made that early treatment doesn't work.
Yep.
Early treatment is ineffective. Early treatment is useless. You're going to have to start over at 11 anyway.
Right.
Why?
Makes no difference in the end.
Makes
Right.
no difference in the
Yep.
end. But that's one conclusion. Another conclusion, I have a different conclusion, is why don't we look at the techniques used and
Thank you.
see
I was
there might have been a
Yep.
deficiency
Yep.
in the techniques.
Yep.
So when
a lot
I
of
was
that was
cleaning,
a lot of that literature you're studying was headgear, lip bumper, lingual holding arch, Nance, really,
upper expander only,
upper only. Sure. I mean,
upper
not only
expander only,
occasionally
which,
upper expander only, but I mean, McNamara is one of the few. I mean, again,
yeah,
that going back in the 60s, Schwartz and Gratzinger kind of popularized this concept of lower arch expansion. And it was McNamara is one of the few to bring it mainstream in ortho. And he has a paper, I think it was late 80s, early 90s, that talked about how you get a better result. It was in the 90s, a better result by expanding the lower with a Schwartz appliance, and it's stable.
yeah.
So there are tons of data out there to substantiate the fact that lower expansion combined with upper expansion is better. But you're right. There was this movement. And in that, they didn't look at what was done, how it was done, when it was done.
Sure.
And when I read those articles, I get so frustrated because I'm looking at this and I'm like, this is bogus approach to phase one. I'm sorry. Like this, of course, it didn't make a big difference. They didn't do it right. I mean, if you mentioned, treat someone with orthodontia or Invisalign and you don't use the right approach to doing it, it's going to look like you didn't do anything. Right.
And putting in a control arch or a Nance, those are holding appliances. Right. Those are retainers.
Right.
That's not early treatment. That's early retention.
Yep.
So you actually take away any possibility the kid could get a little bigger on their own.
Agreed.
So that's a retainer. So you're putting in these retainers. Of course, they're going to look the same at 11 than they do at 8 because you glued a bar in there.
Right.
So the conclusions were all wrong. And so certainly, that was a big problem because it set the tone for GPs being pushed back to referring at 11.
Yep.
Because we can't do anything early. It's ineffective. And then, that's incredible to me that kind of won the day. But, like you said, there were expansion people out there early and things go and it flows. And, I'm a big believer in like natural cycles. In natural cycles, you go way back. You had this expansion group that was doing foundation work, and it's not a new thing, lower arch expansion. Schwartz has been around forever, and Angle and Bogue, like you mentioned, they're 100 years ago.
Yep.
And then it fell out of favor. And I can see, well, here comes that natural law swing. We're going to come back to that.
Yep.
And we're going to come back to that. But then I don't believe we're going to go the other way again because, natural law has a way of going up and down up until you find a point where you have really good balance, and then it has its plateau.
Yep.
So I have a feeling when the expansion world kind of takes over again and we get this non-extraction growth and development early treatment pattern in enough places, when it wins the day, it'll become the standard of care again. And it'll be the standard of care and go forward and maintain a plateau. I don't think we'll ever then devolve into, we're back to extractions again being better.
I hope not.
I hope not too, because that's not helping the kids out. So my pathway was through early education, early treatment, getting involved. But then one thing led to another, because in the beginning, here I am just working on the kid by myself. I'm doing my work. I didn't know there was a collaborative effort going on. I had no idea about myofunctional therapy early. So when I was starting this out, the early 2000s, I didn't know this existed, and it has existed forever. Now that I know the history, this has been around a long time. And so I got introduced to myofunctional therapy. Then I got introduced to frenum attachments, diagnosis and releasing, because tight frenum do affect growth and development. Then you get introduced to nasal attention, because nasal breathing happens to be the opposite of mouth breathing when it comes to healthy and unhealthy kids. And one thing leads to another. And all of a sudden you're learning things that, okay, so there's a team approach to helping that child out. We need to do our job. We need to get them to a myofunctional therapist. Everybody needs to work on getting this kid breathing through their nose again, because you have to convert that mouth breather to a nose breather to have a healthy child. So year after year after year, I'm picking up these new pieces of my puzzle, and sure enough, the outcomes are improving. and the treatment is improving, the outcomes are improving, and now these kids are growing into beautiful, healthy occlusion. That second phase is simple.
Mm-hmm.
They're turning 12.
When needed, when simple, when
if
needed.
needed.
Yeah, if
If
needed.
even needed,
Yeah.
you're right.
Yeah.
We had a group of, we have a percentage of kids that when we do it early, they get nothing later.
Yep.
We have that percentage. And the kids who get something later, it's simple. I'm doing aligners mostly.
Yeah. Yep.
So that 12 on up, from 12 on up, I'm making these kids a few aligners to finish the detailing of the teeth for perfection. Because, what parent doesn't want perfectly aligned teeth? I get that. Get the foundation early, get the child breathing through the nose. They sleep better, they heal. And these little pieces were put together. And then I started teaching in about 2011 to 12. Because right around 11, 12, now I had some really good years and a lot of examples of success.
Mm-hmm.
So now we're talking about 8 good years of treatment with success, building PowerPoints with case after case after case, sharing my puzzle of the pieces I've accumulated, understanding anthropology, because that was a whole nother piece that was incorporated into learning, where's this all come from? And how did we get here? Because then you can unravel it. Okay, now I can focus on treating the cause better. And so you learn anthropology research, you learn early soft diet, you learn muscle dysfunction. And when you learn about soft tissue dysfunction, then you put your focus on that. You then recruit the muscles to grow your jaws with you as opposed to fighting against them. So all of a sudden, that's where the myofunctional therapy component, the releases come in. Get your muscles working for you. It supports everything you're doing, going wider and forward. And the body wants to heal. You just got to give it some direction.
I want to take a moment to thank the sponsor of today's episode, Retainers for Life. We all know how stressful in-house retainer fabrication and replacement can be, especially during those busy summer months. And that's why you need to check out Retainers for Life. Retainers for Life is an affordable and convenient retainer replacement program that not only fabricates custom retainers for your patients, but they actually deliver the new retainers directly to your patient's doorstep. And the best part is that you, the doctor, get to maintain control over the retainer design and material, set your own fees, and generate additional revenue for your practice. Plus, as a very satisfied customer of Retainers for Life, I can honestly say that the entire team is truly amazing and will be there to assist you and your team from onboarding to implementation. So go to afterorthorevenue.com and schedule to book a discovery call now with a Retainers for Life team member. And be sure to use my exclusive discount code DOC2024 to get $2,500 off your enrollment fee. Again, that's afterorthorevenue.com. Use my exclusive discount code DOC2024 to get $2,500 off your enrollment fee. Trust me, you won't be disappointed.
2011, 12, you start doing small study clubs. You're getting invited to a little study club here and there, share your work, but then people see and they want to learn more. And then it starts to snowball. Now, at the same time, taking early treatment, I figured, well, since I've seen what braces do from 11 to 14, and I'm unhappy with it, I probably should take this clear aligner course given by Invisalign back in 2003 or 4, whenever I took it. I said, I got to go see what that is, because I know the alternative is not working for me. So again, I just use my little common sense and logic. I should go check that out. I sit in front of a course and I was blown away by what I saw. I went back to the office and I started doing that on everything I could get my hands on, and the patients loved it and wanted it. Hundreds of cases later, within 24 months, I was teaching and a faculty member, and I spent a good 17 years teaching at Align. Only up until recently, about 3 years ago, I did resign from that position to move to a different aligner company today. And sure enough, I'm with them for the last 3 years doing things just a little bit differently, but still big fan of clear aligners, which we use a lot on kids in the second phase because it's simple, clean, and easy. And you can do wonderful things with clear aligners as they're more capable than brackets and wires in some instances.
Especially when the foundation has been set so well. Interceptive.
If you have a beautiful foundation, the aligners are a nice choice later on. So I'm a big fan of that. And I also use some bracket and wire technique in a second phase because I'm not opposed to braces when it's second phase, full foundation, nose breathing, no symptoms, myofunctional therapy. Like when you have the right base, you can use braces beautifully to shape an arch. And they come with broad arch wires. I'm a fan of self-ligating brackets, so I'm afraid to say it. I learned it at UConn. I know where you went, but I went there for the training by Dr. Louis Carrier. Carrier, I'm probably pronouncing it wrong. He developed that beautiful system with the Carrier brackets and the broad arch wires. So I went out to UConn and was trained by him how to use them. And I got introduced to those early. I feel like I'm using them for about 20 years now. And so I'm a big fan of the self-ligating broad arch wires, the NiTi, but I don't use braces alone. In other words, like I don't meet an 11 or 12-year-old and say, oh, you're going to get braces. I'm much more comfortable, and I know you can do that. I understand you can do that. But for me, braces alone was never a match. So I always focus on the foundation first. I'll do whatever it takes to get the foundation the right size. Then I'm not opposed to using braces after for tooth alignment. And so I do recognize that you're very capable with beautiful, technique with brackets and wires alone. I understand you can do it earlier in all ages. I'm not at that level yet.
And that's an really interesting point, because I think a lot of people in the orthodontic arena, there's this divide and between orthos being like, look, GPs shouldn't be doing this. And I'm sure you've heard that a million times. And
yes,
I will say, I used to think that. I did. I actually did my master's research at UConn on, this is kind of ironic how things happen. And I mean, who would have thought why they ended up being this? But I was always curious about that. Maybe because I had GPs in the family. None of my family members happened to do any ortho, but it was something I was very interested in. And it was really being talked about a lot in the early 2000s. And maybe in line with what you're saying, you guys started kind of this undercurrent of like, wait a minute. And this was the point I wanted to make. The vast majority of respondents said the primary reason that they got interested in and pursued performing orthodontic treatment was the orthodontic results were unacceptable. And the secondary one was what you said, too much extraction of healthy permanent teeth.
Right.
So I had never told you that. My master's studies out there on the internet somewhere, but I'm sure you probably haven't read it. Take the time.
I did not know that coming in, but you got from me just freely saying my dissatisfaction followed by my extraction was the last straw, that I felt like I needed to offer the kids something different. And, I know I've heard the comment, GP shouldn't do ortho. I've been told you shouldn't be doing ortho. And, my snide remark back was, don't worry, I'm not doing what you're doing, because I know the people saying it to me and what they do. And so I would say, don't worry, I'm not doing what you're doing. You don't have to worry about what I'm doing. It's different. And so it was different on purpose because I saw that result. And look, I know the research too, where the completion of orthodontic treatment doesn't offer stability. Retention is for life. Like there's a disconnect. There's something missing because if you're going to spend that much time and cost that much money and have that much effort into treating a child, but have absolutely no stability for it, you got to rethink this technique. And so I think the disconnect with some of the ortho specialty out there is that they're not following people after the 2-year retention mark.
And that's another great point. We're not. I mean, we're just simply not, until they come back to our office because they lost or broke their retainers, or something happened and they come back and want new ones, or they stop wearing their retainers and things shifted. And obviously over time, there's shift that happens later as we age and grow, and you get kind of some wear of the teeth, just natural function, and you can get some of that incisor liability there. But you should have the arch dimension, the arch width should remain stable. You should be able to have really fundamental stability, other than the change. I always say to my patients, our bodies are dynamic. Everything changes with time. So over time, based on how you wear your teeth, if you say have some restorations done, and all sorts of things can happen, and you can get some shifting, especially patients if they start to clench or brux or stress, and you start to deepen that bite anteriorly, you'll get a little buckling of those incisors. But I agree with you that this collapse that I would see in a lot of traditionally treated ortho cases was something really bizarre to me. And I would see this because as my evolution in practice, and kind of how I came from being someone who did it the traditional ortho way to doing it more of that sort of progressive early treatment, growth and development way that you're discussing, which makes me essentially an outlier within my own orthodontic community, but proudly so, because I know what it let me do for kids, and I kind of wear that as a badge of honor. But I still have a great respect and appreciate what you said, is that orthodontists, a lot of us too, but we're amazing at straightening teeth and at being able to do a lot of great things with our treatment. And I think the disconnect is an interesting thing to touch on, because fundamentally, we're all trying to do the same thing, get a great, stable, aesthetic, functional result for our patients, right? And we can argue about how to get there, fine. And we're never going to all agree on that. And that's not even a bad thing. The challenge is there is a fundamental rift between traditional orthodontic education and treatment approach and what we're talking about doing, which is what you do and what I was doing in my clinical practice, is going in younger than we were ever taught or exposed to, treating them and developing these arches, minimizing extraction. And the one thing I want to touch on, which I want to hear your take on, I think the whole extraction debate gets really interesting because people, I say they, but the traditional orthodontic community talks about, extractions don't cause airway problems. Extractions don't cause instability, all of these other things. And I think it's a bit of a sleight of hand because what really is, they're technically, they're right? It's not like you pull teeth out of an arch and the patient has a sleep-related breathing disorder, right? All right. It's not like you remove teeth and all of a sudden the patient within an hour starts having these medical consequences and issues. So technically, you could say even within a few years of treatment, right? Extract the teeth, you look at the baseline and how they're breathing, you go in, you do your ortho, that constriction, you don't address the etiological basis that's there, the transverse deficiency and all of those things that we're going to talk a little more about and you've touched on. But what you're not quantifying is you miss the opportunity to make it better. And so it's sleight of hand. It's like, well, we didn't cause the problem. That's not the question we should be asking. The question we should be asking is, did you help the problem? Did you diagnose and detect the problem as the etiology, which was contributing to this crowding and narrowness and transverse deficiency? And then if you detected it, did you do anything about it? Or did you simply try to straighten the teeth? And yes, I've seen the studies. There are a lot of studies that say, like, this patient had a, which we can talk more about AHI and that whole parameter anyway in kids, because a lot of that's bogus in terms of what it really can do to quantify the actual child's sleep-related breathing issues. But let's just go with it for a second. And they say, oh, it didn't change, through whether we extracted teeth or didn't extract teeth. Oh, and there's a study of expanders, and it didn't change if we extracted or didn't, or expanded or didn't expand. The problem is you have two main challenges. One, as I said, AHI is a faulty indicator in children of whether or not they really are suffering from these issues. So that right there becomes kind of a fallacy, and you're kind of almost like a false flag. You're saying like, "Ooh, look at what we're doing here. It doesn't change anything," but your measurement gauge is inaccurate.
Yeah.
The other part of that is, as I started to allude to before, well, maybe you didn't notice where they came in, and maybe they had this problem that you could have helped had you gone in there younger, had you gone in there and not done this watchful waiting, which a lot of people, myself included, feel can oftentimes be supervised neglect. Not that you don't watch and wait on some kids. Of course, I mean, I had a huge recall pool in my practice of kids that came in at 6, 7, 8 and didn't need anything, had broad arches and maybe a little deep bite or a little crowding or a little, and they fine, right? But knowing when you need to go in and treat the ones that did need treatment, and taking those kids that come in at 6 or 7 and are really crowded and like, I think we'll just see how they grow. And then at 10, 11 being like, they didn't grow very well. We're going to pull a bunch of teeth, and missing the indicators were there. I guarantee a lot of those kids, if you did something like rhinometry, like we were saying before with rhinometry or rhinomanometry, and looking at their airway, looking at even just as a cone beam and looking at nasal passageway patency, lymphoid tissue obstruction, oropharyngeal constriction, tongue space, scallop borders of the tongue, dark circles under their eyes. Is this an allergy patient? All of these things.
Yeah, a simple sleep breathing questionnaire will tell you the symptoms.
Simple sleep. Thank you. I mean,
behavioral issues. Is there an ADHD history? Bedwetting, night terrors, night sweats, waking at night,
or school performance.
Yep. The whole entire category of all teeth grinding.
Yep.
All of these things are simple symptoms. And with that, you have underdeveloped jaws, you have a breathing issue.
Thank you.
One of the big disconnects is that I think the ortho specialty is looking for the OSA. They're focused so much on OSA. Well,
yes.
So few kids
that's what I was indicating with the AHI.
Using
that index for OSA.
You're saying AHI.
Correct.
Yeah, well, you're missing the boat. So I like to kind of throw an analogy in there to think about it differently, because if you're waiting for OSA, that's the worst possible breather you could be.
Right.
But that's not where bad breathing begins.
Right. It's end stage disease.
Oh, yeah. That's an end stage disease. Yep. And yeah, sure, maybe 3 to 5% of kids have OSA. But I can tell you 99% of the kids have a breathing disorder. And their poor breathing, we say sleep disorder breathing, but they're poor breathing during the day. They're worse at night. You're a bad breather during the day. You're worse at night. Very few kids nose breathe day and night. And so There's a huge difference between nasal and mouth breathing. And your only pathway to be a healthy human being is to breathe through your nose 24/7, 365 without resistance.
Yep.
But the moment you have nasal airflow resistance, you're unhealthy. So you can have your lips together and have resistance, and that resistance will trigger the sympathetic nervous system. So you're in fight or flight with nasal airflow resistance. That's the beginning of the problem. When that resistance level rises enough, your brain separates your lips, and now you're a mouth breather.
Yep.
Now your problem gets worse.
And I want to stop for one quick second, because that's something people get confused on. And your episode's going to air shortly after Karen Parker Davidson's, and she talks about how you need some resistance for the Bernoulli effect to enable to have the air to get through, but which I know you're not saying is not correct. But for people who hear that and say, well, wait a minute, I thought we just heard someone on saying that you need resistance. No, you do need resistance, but what we don't have a good way to quantify exactly how much. And Karen talks a lot about that. We're getting better with random manometry and acoustic rhinometry. We're getting better, but we're still not there yet. But what I hear you saying, and just to clarify for everybody, is yes, the resistance you need to get the appropriate airflow to circulation through the nasal passageways. But when you get that
very low amount, though,
right? When it goes too high,
non-resistant nasal airflow is appropriate. But when you're talking about resistance and flow, as the resistance climbs, that's when the sympathetic nervous system activates to start compensating.
Right.
Mouth breathing isn't by accident or by intent. It's subconscious. Your brain will relax the muscles to open your mouth when the nasal airflow resistance gets too high. So there is a healthy, it's like carbon dioxide. There's a healthy amount. And then when there's a little too much, things go haywire. So you don't want too much carbon dioxide. You need a healthy amount. The resistance level is low, like a carbon dioxide. A low level is appropriate.
Exactly.
Too much trouble.
Good analogy.
Once your resistance level reaches a certain point, you're in a bad space. And that doesn't mean you have OSA, and that doesn't even mean you have an AHI of 1. You could be 0 AHI.
Completely could be, because if you have an apnea or hypopnea episode of less than 10 seconds, I mean, you could be at 9 and look like
you're at 9 all night long.
All night long, and be like,
100 times at 9, you're good.
My sleep study's great. No.
So I like to throw my analogy out there that people start getting a different perspective. What I call OSA, I analogize this. OSA is stage 4 cancer. Nasal airflow resistance is your stage 1 cancer. That's where your problems begin. So nasal airflow resistance, and with parents, when you're talking to them, these are fancy words. Does your child breathe through the nose and it's silent and invisible? Because that would be appropriate. Now, we can't quantify that, but however, if you can't see or hear your child nose breathing, that's a good breathing pattern. You should have to go up to them to know, like, wait, is there air coming in and out of here? From 1-2 feet away, if you can tell your child is breathing through their nose, you can see or hear it, that's bad breathing. That's too much resistance. So the level of resistance would be that it's silent, invisible nasal breathing up to a close distance. Then I know that child's breathing well. Meanwhile, nasal airflow resistance, I try to teach people, like, look, that's your stage 1 cancer. So no one in their right mind is ever going to hear a doctor say, oh, we found this cancer, but it's stage 1. Come back when it's stage 4. No. If your nasal airflow resistance is significant enough to trigger some mouth breathing or symptoms of sleep fragmentation, which are easy to ask, you have a stage 1 cancer. You've got an early problem that needs attention then. Why would you wait for it to become OSA? Because OSA is not an acute injury. It's a chronic deterioration.
Why aren't we talking? I mean, I so agree with you. Why is this not discussed? I just...
Even the medical community has a little...
sorry, I should have said that. OSA. Medicine, dentistry. Why is this?
I have heard the medical community say mouth breathing is healthy for you. Mouth breathing's fine. Meanwhile, mouth breathing is not. That's a compensation. It's a relief valve. You know what mouth breathing is? And I don't want to take credit for this because I believe I heard it from someone else. I just don't know who to give it. Mouth breathing is your body's form of early CPR.
Makes sense, right? Right, sure.
You can't breathe through your nose, your mouth will open. It's a safety valve. It's how you save yourself from expiring.
So how do physicians reconcile that? Because American Academy of Otolaryngology Head and Neck Surgery, who puts out a lot of data on this, they say openly that any amount of mouth breathing is inappropriate and should not happen.
And the pediatric literature shows the mouth breathing kids have the much higher rates of any ENT and respiratory illnesses compared to nose breathing
and
children.
Neurocognitive deficits.
Neurocognitive deficits.
I mean, it's a lot of David Gozal's work talks about. I mean, it's not even. We're not. And to be very clear to our audience, we're not talking about OSA and a high apnea index. We are talking about even mild mouth breathing has been shown data are very
Very
clear
unhealthy.
that it is very
Cognitive,
unhealthy. I mean,
academic,
the Karen
behavioral.
Bonnick studies. I mean, like
Dr.
there's
Bonnick, Dr. Gozal,
it
and
goes
Dr. Gozal,
like
husband-wife team.
it's just
Incredible. The
I
documentation out there. Yeah, so I spend very little time talking about OSA because
agree. Me,
immediately
me too. Yep,
I'm
me
in the
too.
mouth breathing
Yep,
category. If a parent tells me by observation they see their kid mouth breathing, that's an unhealthy child. The
yep.
symptoms will be there.
Agreed.
So we don't meet 3 to 5-year-olds who are healthy anymore. And so when you're going through a full sleep breathing questionnaire, it's an absolute unicorn for a parent to report on a detailed health questionnaire that is a sleep breathing questionnaire that their child has no symptoms between 3 and 5. So to give you an example of this, I just screened just under 7,000 kids I've screened in the last 6 months.
Wow.
And so that has to do with the company Tooth Pillow, which maybe we have a minute for later. But anyway, parents submitting sleep breathing questionnaires and some photos for me to do just a screening. I'm using the word screening, not diagnosing. And so 3 to 12, just under 7,000 I've been through. And there wasn't one child that didn't have at least one symptom. And so all of a sudden you have multiple symptoms.
And these are questions regarding just their, like we kind of
Oh,
alluded
yeah,
to before.
25 different points on everything from does your child mouth breathe during the day? And then it's never, sometimes, often, always. Like they're given a range of it. Does your child mouth breathe during the day? Do they mouth breathe at night? Do they snore at night? Do they gasp or hold their breath at night? And so it's done by observation. And then, of course, the questions are bedwetting, ear infections, frequent infections, allergies, restless sleep, waking at night. It goes down the whole list of things. So you can get a whole history on a parent with these 25 points, behavioral, academic. It's all in there.
Okay, good. Yep.
Tell me about your child, right? Tell me about your child. You learn about the child. And it turns out when you correlate what they're giving in responses, which in the 3 to 12-year-old range, we're meeting kids who have 2 or more symptoms generally. But then we're also meeting kids who are on medications very early, as young as 3 and 4, for the symptoms that they have. And medications are treating the symptoms. So when you look at that and you correlate to the teeth, well, if they're 3 to 5, guess what? The baby teeth have no spaces. That's what you'll see. No spaces, deep bite. And right away, that's a collapse of tongue space.
And people out there will say, oh, they'll outgrow that. No, I teach them this all the time. The more mouth breathing begets mouth breathing, nasal breathing
it
begets
gets worse
nasal
over
breathing.
time. So
and not
malocclusion,
only,
you're not correct.
When you have that mouth open, just the simple, I talk a lot about, there's people who say the Melvin Moss and functional matrix and Enlow's growth concepts are inappropriate. I don't even know how they say that because there are, again, plenty of data to substantiate that when you have an open mouth or you redirect your growth to be more vertical in nature and you restrict the transverse growth and you get those collapsing arches. And so you see it and it just keeps getting worse and worse and worse. And a lot of people, I said, when I was going young on these kids, a lot of I stopped having to worry about, unless there was just that random genetic, which happened, but not often, incredibly vertical grower that is just, growing completely with mandibular prognathism and just this, open bite. You're going to see those every now and again. But what I stopped seeing was I got in there early on these kids and redirect the transverse. My persistent open bite on an otherwise sort of normal growing patient went away. I was not treating open bites in teenagers unless they didn't come to me until they were a teenager. But it was, and so I'm like, I can show case after case where these kids started a little bit open. You go in and address that transverse and get at that etiology. Make sure do the things we'll talk more about with working with our colleagues in ENT, allergists, myofunctional therapy, and all of a sudden, you go in a year later, everything's closed down and you retain them with a couple Essex and then they outgrow those and the bite stays closed. And it's like, oh, wait a minute. And so for the people who say that if you just let them grow, what do you say to that?
Yeah. So they won't outgrow it. That's Dr. Bogue's research. You know, in the dental community, pretty much everyone across the dental community knows when they see a child in primary teeth that are connected with no spacing, that's going to be crowded teeth. And if you see a baby tooth that's crowded, a set of crowded baby teeth, you got severe crowding coming. And Dr. Bogue's research was pretty significant in that early malocclusion, there is no such thing as spontaneous correction or outgrow. And he did a lot of transverse measurements. He was measuring between A and J. He taught us that if you're under 30, you got a problem coming. Like 30 was like a bare minimum. He knew at 28, you were going to have significant crowding between A and J. And he tracked these kids over time.
And he was expanding them in the primary dentition, if I'm not mistaken.
Back he was seeing them early.
19 teens.
When he was, it's 100 years ago, his research, what he was showing over time was when you just watch the primary teeth, if you don't have significant spacing and a good width, you're going to have crowding, and it gets progressively worse over time. Malocclusions, they don't maintain similar credentials. They don't improve. They only get worse.
They worsen. Yep.
Yeah, and that's what's happening is that, of course, in the anthropology research, you've got the early soft diet contributing to the underdeveloped jaws, thanks to weakness in the muscles. But once you have the underdeveloped jaws, it triggers the change in breathing.
Yes.
And the mouth breathing is going to add the gasoline to the fire that's already running.
Yes.
And that's where you got Dr. Stenlinder-Aronson, excess facial height malocclusion.
Yep.
Yeah, mouth breathing, I don't like to call it a cause of malocclusion because you had the malocclusion first from the early soft diet. The early soft diet, the weaker muscles, the jaws don't grow as well. There's your trigger for the nasal airflow resistance causing the mouth breathing. You have the underdeveloped jaw from the early soft diet. That's the earliest start of the problem. Then, of course, when you reach the point where you don't breathe through your nose so well, you're going to open your mouth. The malocclusion gets worse over time thanks to the mouth breathing. So the early soft diet is really the cause of malocclusion. Mouth breathing is an additive component that's coming your way. And certainly, Dr. Bogue showed by transverse development. And the interesting part I learned about his measurement between the baby teeth, he knew the gap you needed between the baby teeth.
The Bogue spaces.
The width of a nickel.
Yeah. He had
the width of a nickel. If you could fit a nickel between them, we don't meet children today that have a nickel between their baby teeth. So if you don't have 30 millimeters between A and J and you can't fit a nickel between the front baby teeth, you got a kid who's going to have crowded teeth later on. And it's very predictive thanks to his research. It's not going to outgrow anything. Kids don't outgrow malocclusion. It gets worse over time. And there's no example or any research showing that a child with early crowding of baby teeth or collected baby teeth together is going to be normal teeth where they belong. But when you intervene early, you have the opportunity, number one, to have the right size foundation, which then you get to keep all the teeth. That's wonderful. And have an early second phase. But having the right size foundation and then playing with the teeth later, that's where you get your stability from. Because with the right size foundation, you throw in the myofunctional therapy and the Frenum releases as well, because it's the tongue that is your body's natural expander and grower of the jaws. And then the tongue is your retainer.
Yes, I say that all the time. The more we talk, the more I realize why so many people had told me that we had to meet.
We're saying the same message.
I'm like, as you're talking, I'm like fired up. I'm like, oh my God, yes. But it's exactly it. The tongue does so much of the work, and when you give that tongue room, that's actually why I ended up seeing what I went from. And again, it's the technique you use to do it is I want to
exactly.
There's all different.
I don't care how you do the early treatment. Just do it. Just do it early. Give the right size foundation by measurement, because we have them from Bogue to McNamara. We have the measurements of the width. And so I was going to add to the width, like you noticed, when you're treating the width appropriately, you'll notice differences at the anterior, improvement.
Completely.
Well, I can tell you from my 21 years, when I treat the width, the sagittal self-corrects.
Oh, you see that a lot of times. I agree. And McNamara did. That's kind of some of McNamara touched on that in sort of the foot in the shoe research. I think he had where it was like, oh wait, I'm seeing in some of these patients when I'm expanding the upper, in some of them that mandible, their class 2 gets a little better. And I would see this in cases time and time again. And I ended up getting involved from transitioning from expanders to doing with braces and wires on young kids, just because it was just easier and easier for them to tolerate. And people would be like, there's not enough force. And I said, one of the things I realized was happening that I didn't honestly know when I was kind of starting in the process was the tongue had the freedom without the expander blocking it. The tongue was doing so much of the work for me, because once I started getting the alveolar, even if it was dental alveolar tipping initially, you're starting to broaden that arch. All of a sudden, you'd see this palate start to reshape. And I have pre and post treatment CBCT images on these kids showing the osseous change of the orthopedic nature in the palatal bone. And it's like, oh my gosh, there's more going on than we even understand. And I think part of it might be the problem, is because academia hasn't kept up with this, because we're not teaching our orthodontic residents this by and large. There are some wonderful outlier programs, but the vast majority aren't learning what we're talking about. They don't understand it. And they've spent so much time and energy going down the path of tooth straightening, right? And dealing with, like you started in the beginning saying, these preteen teen kids, and figuring out how to make it all fit the best they can. And oftentimes having to pull teeth to do that to tell them, hey, wait, everything you just learned, you've got, keep the part about the biomechanics of moving teeth, because that's really good to know that.
Part 2, you've got part 2 covered. We need to give you it early. We need to give you the early, the prequel. Let's give you the prequel to the movie. You've already got the movie. So the tooth-focused approach is late. You want to do the early work. And so in my world, where I come from, like with McNamara's research, et cetera, The more narrow the upper arch is, the more trapped the lower is. The lower is a victim. I like to say that the maxilla is your criminal, the mandible is your victim. And the maxilla gives permission to the mandible to land. The maxilla is going to be the criminal, the mandible the victim, meaning whatever your maxilla has grown to, and it's underdeveloped in almost all humans, then your mandible has to land in there. Well, the more narrow the upper is, the further back or trapped the lower jaw will be. And it turns out as you start to expand, you see the relief of the sagittal. So in my world, the transverse discrepancy causes the sagittal discrepancy.
You see it,
which is why when I deliver the transverse correction, the sagittal self-corrects. Now, the degree it will correct will be based on your starting measurements and the distance you're going. So in my world, based on Bogue to McNamara, but also factoring in anthropology research that gives really good transverse measurement on what humans used to be. What does a normal human population grow to in the absence of a soft food diet? So I happen to know those numbers along the way. So now it turns out I do a significant amount of expansion, upper and lower. So I don't meet a child that I would want to use expanders on and only use an upper. It has to be upper and lower. My bare minimum, we don't put expanders in a child without giving them 8 millimeters. You're going to have to do 8 millimeters minimum. However, you also have to get the upper transverse 3 to 14 measurement. You got to get to 40 as a minimum. You need to achieve both numbers, an 8 millimeter minimum and a 40 millimeter minimum. And here's why. Some kids are going to come in and they're going to measure 28. They're going to need to get to 40. Obviously, that's 12. And it doesn't matter what they measure. They could measure 25. They need to get to 40. 40 is a bare minimum number to house the first 28 teeth and give you a coin toss on the wisdom teeth coming in. Now, there are kids who are going to come in at 36, but we're not going to 40. They're getting 8. And here's the rationale. When they come in at 36 and they're showing you crowding, you need to go through the sleep breathing questionnaire because they're going to have symptoms. Some kids have symptoms at 25. Some kids have symptoms at 36. So the kid who comes in at 36 with crowded teeth and symptoms, they get 8 millimeters. They're going to 44. 40 is a minimum target. Now, what that has done for me is knowing Bogue, knowing McNamara, my last piece of the puzzle to add to the distance forward is the anthropology research. So I've had the opportunity to have conversations with Dr. Robert Corcini, malocclusion anthropologist out of Southern Illinois University.
The pig studies, the Corcini pig studies were legendary.
Brilliant man. And his book, his textbook is how anthropology informs the orthodontic diagnosis of malocclusion's causes, early soft diet. Dr. Jerome Rose out of the University of Arkansas, head and neck anthropologist, also malocclusion expert. So these two gentlemen have almost 100 years of work in anthropology regarding malocclusion. I don't think there are two people on the planet who've looked at more skulls or measured more skulls than these two guys. So I've had a chance to ask them, hey, since they were doing hundreds of measurements on all these skulls, when you have a pre-industrial, pre-Western, non-soft food, early diet culture, what would you find as like an average arch width? Between 3 and 14? 55. The number is 55.
Wow.
55 is normal average human growth and development. I'm going to get to 40 as a minimum. But you know what 55 corresponds to? 99 point something % of the wisdom teeth are there. All the skulls have 32 teeth where they belong pretty much. So you have this beautiful uniform occlusion, consistent across different cultures around the planet. And then you have 32 teeth to show for it as well. So you've got a pattern that demonstrates what a normal human would go to. 55 is an average. So I asked them, my follow-up question was, what's the lowest number you've ever encountered? Pre-industrial, pre-Western skull measurement. 50.
Come on, 50?
50. Now, this is with good growth and development.
People would say pre-industrial, talking pre-industrial revolution and manufacturing.
Pre-industrial, pre-Western. Now, industrial Western models start Far East and work their way over. U.S. is last when you talk about industrial. So it comes from East, it gets to England, it hops the pond. So basically, when you track that early soft diet increasing, you track malocclusion right behind it. So it's an acquired condition. But the cultures where you're looking at these pre-industrial, pre-Western living cultures with, the early soft diet doesn't exist. There is small rates of malocclusion, but they find it funny in the aristocracies. So the less than 1% are the king, queen, prince, and princesses. Those populations are buried separately. Those are the skulls that have the underdeveloped jaws with the crowded teeth. The masses, which is the 99+%, the masses have well-developed jaws with 32 teeth, and they have the good measurements. So you can find some hints of malocclusion in aristocracies because the babies were fed differently. The reduction of breastfeeding begins in the aristocracies. The babies are taken from the nurses, and they're fed by feed bags. The food is ground up, mushed up, put in a bag, and they squeeze it in. It's like it's the early day. It's the precursor to the bottle. it looks like a cake decorating bag. You know how you
Yeah,
decorate,
yeah,
right?
sure.
Happy birthday.
Yeah.
They fill the food in that and they squeeze it in. It's like an early version of the bottle.
Interesting.
So you take away the breastfeeding and you take away the natural hard diet that the culture is having. And sure enough, you start to see the rise of it. And then, of course, soft food takes over in industrial living. So now you have these numbers where, Bogue knew at 4 years old, you needed to be at 30 because under 30, you're going to have crowded teeth. Your wisdom teeth won't fit. McNamara knew 35 to 39 was a range
Hmm.
that he saw. When he tracked growth and development over time, he knew that small population of kids that doesn't need ortho and they grew up okay, their transverse was 35 to 39. And I think his research showed of all the measurements they were taking, panoramic, cephalometric, intraoral, extraoral, that one measurement, the distance between 3 and 14, became the single most important factor in determining did a child grow perfectly and not necessarily need orthodontics. I think it was the only statistically significant measurement that could predict normal growth and development was the width. And they would land about 35, 39. But the
Yeah, I remember that
significance
study that
40,
McNamara had on that. Yeah.
40 as a minimum, you know what that gets you? It gets you wisdom teeth at a coin toss.
Hmm.
You're a 50-50 shot. If you could be 40 millimeters between 3 and 14, you're a 50-50 shot at your wisdom teeth. So we like to get to 40 early before 12, because if you have the myofunctional therapy and you keep the guidance going, you should keep growing because your jaws do grow a little more later on. If you could keep growing and get above 40, you're just increasing your opportunity for your wisdom teeth.
Hmm.
So getting to 40 eliminates extraction. There's no such thing as needing an extraction. I'm 21 years in. I haven't taken a single tooth out. I've treated the craziest of crowding.
Hmm.
But really, I don't see crowding anymore. I just see smaller jaws. Go for the foundation.
Yeah.
You go for the foundation, there's no crowding to see then.
And to clarify, I think a lot of people here, just because I know people will say, or I'll get comments or emails on it, like, "Oh, you can't expand a mandible after birth." That's not what Ben is saying. It's not what I am saying. We're not doing distraction osteogenesis here and going in for a mid-sagittal cut and putting distractors in these kids. We are talking about a broad mandible, and if you look there, you probably know this from the anthropological data, that most mandibles fall within a very tight range of width. You do not see many small, narrow transverse mandibles in terms of the bony base. You see tremendously narrow arches because they've compensated to try to fit, as you said, the
alveolar complex is collapsing in
to fit this narrow maxilla.
And there
is
is
compensatory.
Research. Compensatory collapse.
Yeah.
But you're going to see in the anthropology research that with the early soft diet, the entirety of the mandible is smaller. You have a smaller mandible than obviously you have this delineation between early hard food, which is pre-industrial, pre-Western cultures. They have bigger mandibles, bigger condyles. When you have a early soft diet, the muscle, the tongue, loses its strength and function. And primarily you grow your maxilla and your mandible by muscle activity. Your maxilla and your mandible do not grow by your genes. They grow by your muscle activity, much different than the rest of the bones of your skull. Your skull is going to grow by the brain growth. Your jaws are going to grow by muscle activity. So your genes, you're programmed to have a maxilla and have a mandible, but you're not going to grow them to the proper size without proper tongue strength and function. So getting involved,
the functional matrix, Melvin Moss. I mean,
you're going to need the muscle activity.
Between form and function.
One of the tragic examples of it would be if an infant is born without a tongue.
And you're, of course, I wanted to clarify too, Ben's not talking, there's, Pierre Robin and syndromes and things where you have altered.
There are syndromes. There are a few syndromes.
So there's a genetic component, but if you don't have that diagnosis or those altered genetic states, and you have sort of a normal genotype in that sense, then the environment, when you're seeing
the size of your mandible and your maxilla,
you're seeing.
So certainly what happens is it was the animal studies that really set that in motion, because the anthropology community immediately did hard soft diet studies on animal groups. And when you do a hard soft diet study on an animal group, and one half of the animals are going to get their normal habitat food, hard, but the other half's going to get the same food blended, softer. They grow a smaller mandible, so you have a decrease in body size. You have less dense bone, body wide, just from the consistency change. You have a smaller maxilla, a smaller mandible, higher vault, narrower across the board, but you also have the condyle smaller by another deviation. So the mandible does become smaller thanks to the decrease in the tongue activity. So when we're using expanders, and I use the word expander loosely and I say expansion loosely, but the expander is going to give you a full correction dentoalveolar.
Right.
You are going to help the mandible grow in size by using the tongue. That's where the myofunctional therapy comes in, because it is the tongue's job to grow your mandible, and with an early soft diet and a weak and dysfunctional tongue, you're going to have a smaller mandible. But you have an opportunity early to correct that. So the quicker you get involved with myofunctional therapy, Frenum releases, you have the opportunity to grow. So to say you can't grow the mandible, well, the mandible is going to grow on its own if you had a proper tongue.
Mm-hmm.
So yeah, you can grow the mandible. Your tongue's job is to grow the mandible, but an infant without a tongue does not grow a mandible. So you get like a linguini strip.
Mm-hmm.
Get a framework. There's a framework for that mandible, but it will not grow over time because you need muscle activity, you need tongue activity to help that bone grow. So we use the expanders to gain our transverse width and correct all that excess lingual inclination. A lot of dentoalveolar change. But immediately with the myofunctional therapy, when you're working the tongue and taking the lips and cheeks out of the equation, you instantly have recruited the muscle that is programmed to grow your mandible. And your mandible responds very well to the tongue's activity. So yes, you can grow the mandible. You're going to be using the tongue to do it, which is what grows it in the first place. And yeah, it's restricted tongue mobility delivers small.
Enhancing the natural growth potential.
Your body's
that you have that you essentially
back,
conversely you're suppressing it when you have all these etiological factors that we're talking about. And why, again, I keep going back to where our profession, the orthodontic profession, is falling way short, is not looking at the anthropological data that you just referenced and not looking at these signs and saying, hey, wait, maybe we could get in there and do things a little earlier and help normalize this growth. So we're not dealing with, I mean, I don't know an orthodontist out there who loves seeing that kid walk in at 13 with collapsed arches and anterior open bite and vertical growth and crowd, moderate to severe crowding.
It's not fun to treat it, but they have to treat it. And then it's extraction and retraction, and it's the tools you have at that age. Because again, it's a tooth-focused approach. It's not a foundation-focused approach. Completely. Now, I meet a child at 13. I'm using expanders. I've expanded through the teen years. I use fixed through the teen years. I use removable beautifully. All you have to do is slow down the rate. That's all. You give that bone a chance to respond. You're basically teasing it. You give it a little pressure, you take it away. You give it a little pressure, you take it away. Bone grows by cycling pressure and tension. And so I use bone dynamics, which are, out there and proven. And you talk to orthopedic surgeons and they understand how you grow bone at really, any age. You can work on this. You can start to tease it by cycling pressure and tension. And really, I don't see a limit to helping the jaws to have a better platform. And I can do it earlier, much easier. So I love to. We treat some adults, certainly, but the focus really is earlier is better, because I'd like to avoid treating the adult later. I don't want to have to treat the adult who has OSA and a collapsed arch with crowding. I'd rather treat the child early. That's where you make the biggest change in society, helping the kid earlier, because we both know, even though we might have started working on the foundation, what we recognized was that symptoms were fading away, because I never set out to treat a bedwetter. I never
even set out to treat a snorer or mouth breather. It wasn't.
I never thought about ADHD early on. I'm like, what do you mean ADHD? I didn't even know what it was at a time.
I'm glad you said that. Right.
I'd like to fit the
so many people say, oh, you guys, go be a physician if you want to treat ADHD. And I'm like, I'm not, that's not what I'm even talking
not treating
about.
ADHD.
No.
So in consultations, I'm asking these questions so the parents have to give me the information, because you want to learn about what is the child struggling with, because the research is out there to show if you're sleeping poorly and if you're breathing poorly and sleeping poorly, it will be a behavioral issue during the day. Dr. Bonnick's research goes on. We've referenced it already. So why not help with what we diagnose, malocclusion, underdeveloped jaws? Because if you can determine that, hey, the jaw size is dictating the breathing, which it's obvious that it does when you take certain, math and geometry classes. You need an amount of room for your tongue to be forward so the air can get behind it. You need an amount of room in your nasal chamber for the air to flow perfectly through. So the system that Dr. Davidson's going to talk about, et cetera, in that size comes from maxillary growth, gives you your nasal chamber, and mandibular growth gives you the tongue chamber. And when you have those two, that air flows properly. When the air flows properly, you sleep properly. The nasal breathing child is in parasympathetic drive through the night. Nasal airflow resistance gets too high, you have sympathetic drive overnight. And sympathetic drive overnight is a different human being during the day. And all of it's out there. So I understand.
And that sympathetic drive is the reason why kids don't register on the AHI scale a lot of times, because their sympathetic nervous systems are hypersensitive compared to an adult, and they don't get into these deep 10 plus second, states of apnea or hypopnea. I mean, the science is all there. It's not
all there to see.
Debatable.
And the one thing that they're correct about, because I hear this all the time, the teeth have nothing to do with breathing. That's a fair statement. You're right. The teeth have nothing to do with the breathing. It's the foundation.
Right. They're the symptom. They're the victim. Have you heard about the doc community on Facebook? It's where you can get access to more great content, including case reviews, select clips from CE courses and podcasts, literature reviews, and exclusive promotions and discounts off doc educational materials. Just go to Facebook and search for the Doc Community and submit a request to join the group. And now back to the podcast.
Yes, the teeth are a symptom. The teeth are a symptom. What you see in the teeth shows you crowded teeth, that's smaller jaws.
Right.
Well, smaller maxilla, smaller nasal chamber, smaller mandible, less tongue space. When you close your mouth, if your teeth are close to your tongue, the only place it can go is back.
Right.
If your maxilla is too narrow, your vault is too high, you have a smaller nasal chamber.
Yeah.
And so the pathway to help the child is early. So I don't treat ADHD. I don't treat bedwetting. I don't treat night terrors. I don't treat restless sleep. I don't treat night sweats. I don't treat poor academic performance.
Or obstructive sleep apnea. Or
I don't treat OSA.
Right.
That whole list of sleep, I don't treat any of that.
Me neither.
I diagnose underdeveloped jaws. But guess what goes away? And now that I'm 21 years in, when you get that child to the right measurements, and that's why I say 8 millimeters minimum. And the 8 upper minimum means you have to have the lower Schwartz. And you know what Schwartz is capable of. So I will give that child 8 millimeters minimum plus the 40 achieved, because we talked about the difference between being 25 and 36. 8 millimeters minimum, 40 millimeters minimum, because when you have that much space, you've got your nasal chamber back and you got your tongue space back. Get into the myofunctional therapy so the tongue knows exactly what to do. It facilitates more growth. But once you have the breathing back, you have the sleeping back. And guess what happens? The sympathetic nervous system shuts off. The parasympathetic nervous system kicks back on. And then that's when the behavior changes. That's when the bedwetting stops. That's when the nightmares stop. That's when the waking at night stops. The child sleeps through the night. That's when school performance increases.
That's when they start going from 1 grade behind in their reading to 2 grades above in the reading, which correct. I literally would have parents say to me time and time again. Literally, they would say to me, like, my child, like, and that's almost how we were talking a minute ago about kind of how we stumbled upon this. And I literally just started, and that's what I beg all practitioners listening. And we have a lot of parents and patients that listen as well. And so if you're the parent-patient side, talk to your doctor about this. Talk to your dentist, your orthodontist about what you're seeing happen with your child. And if you're on the practitioner side, listen. Don't just look at the teeth. Look at the teeth, as Ben said, as an indicator that something is going on here, and start to listen and ask your patient. Even if you just start with, because I know a lot of people hear this and can I get feedback on the show and like, it's just so much and overwhelming. Just start with the sleep questionnaire. Start with just asking the PSQ. I can put a link in the show notes. I've done it before. Just start asking the parents of your younger patients how their kids are breathing and sleeping. And in fact, if you say, but Mike, that's not a standard of care. No, it is. In 2017, the ADA clearly stated that it is our responsibility of all dentists to screen for sleep-related breathing disorders. So it is well within your
children.
In pediatrics. It is our
documented recommendation from the ADA.
Documented recommendation.
We're supposed to be looking for this, because the connections are all there. And again, none of it says that you're treating OSA or you're treating ADHD or you're treating any of the symptoms. That's not. We don't diagnose the symptoms. That's why it's called a screening questionnaire. And it's no different than taking a medical history in a dental office. We take a full medical history.
Great point. You're not diagnosing them with diabetes.
They're going to write down, I have arthritis. I take this. I got cancer. I take that. We're not treating arthritis and cardiovascular disease, but you know what? We might alter our dental technique based on what they have.
Great point, Ben. I'm glad you said it that way.
So taking a full medical history is totally legitimate across dentistry, because there are things in there that make a difference with proceeding with options and care. The right anesthetic. What can we do surgically, non-surgically? What do you have to do? Prepare. Oh, someone's on blood thinners. We do things differently. I don't diagnose your bleeding disorder, but boy, do I have to know you have one. Well, I don't diagnose OSA. I don't diagnose bedwetting, but I should know you have those.
Yes.
Symptoms that could be related to what I do diagnose and treat. And then, of course, you're in a safe zone. You are treating what you can diagnose.
And that's what the ADA says. They said, work with your medical colleagues as needed and perform evidence-based treatment to address the condition. So, and someone out there, I'm still waiting. I haven't seen it yet. Show me data that substantiates that expanding narrow arches in a transverse deficiency is not evidence-based. I've yet to see. They support the documentation that expanding someone who's narrow is not evidence-based. So, and we were talking about too. We didn't even get into it in detail, but working with our ENT colleagues, with our allergy colleagues, getting these patients to see them. I had so many kids who I mean, the parents would say to me, why did the pediatrician never detect their allergies? Why did I come to the orthodontist at 8, the
Right.
first time I walked in the door to an orthodontist, and you're the one questioning me about whether he has allergies and why he's always stuffy? And you show me this 3D image that shows that he can't breathe through his nose. Like, why is this happening now? Why? And the parents want this for their kids
I
younger.
know.
Why wouldn't they? Like, you
And
don't want your kid to suffer.
it's a disconnect, it's part of because separating medical and dentistry early, separating medicine and dentistry, by separating the two, we pulled the jaws out of the medical community. So
Yeah,
there's no training there.
none.
So medical doctors are some of the brightest people, but they're not trained here because
Right,
we took dentistry away from the body.
right,
So you take it away from the body and ear, nose, throat, that's as close as you get, but that's not oral cavity.
right.
It's not the mouth, it's not the jaws. And the medical profession doesn't know it because they're not taught or trained it.
Yeah.
And dentistry did take that road, like we talked about earlier, where we were tooth focused. We've been
Yep.
tooth focused, a profession that is tooth focused for a long time. But meanwhile, in a tooth focused approach, we really only get to treat the symptoms.
Yep.
And even when it comes to decay, that's a tooth focused approach to treat the decay because it turns out the predominance of decay is caused by mouth breathing.
That's
Not
another great
Oreo,
point that people don't
not
talk about.
Oreo cookies and poor
Yep,
brushing.
yep.
The predominance, the number one driver for decay is going to be mouth breathing. The secondary components are nutrition and oral care. But we have
and we again, people would say like, well, how can that be? Well, we know if you mouth breathe, you're desiccating the oral cavity, and we know. Think of any adult patient you have with xerostomia, right? They have you are battling decay in these patients. Like
and that's where the kids are getting it from, the dry mouth.
Again, these are just literally scientific principles that we all in other aspects completely acknowledge as okay. Like, I mean, again, they have a general practitioner orthodontist who tries to say that dry mouth doesn't lead to greater caries incidence in your adult patients. Of course it does. It's
in any age.
But that's what I'm saying is, in younger kids, they don't typically suffer from age-related xerostomia. So what is doing it in them if they're desiccating the oral cavity? Opening their mouth to breathe.
And saliva is your protective layer.
It's your protector.
Taking away the shield by mouth breathing, there you're going to get decay. And we have parents, endless reach out from parents saying, we have a no sugar diet. We only eat healthy. We're natural living. We eat healthy. And we brush our teeth. We clean our teeth. My kid gets 8 cavities, 10 cavities, 6 cavities. It's the mouth breathing. And so you have a group of people that have no component of sugar going in there and great oral hygiene, and yet they have decay. Meanwhile, a nose breathing child could suck on cookies and not brush their teeth. They're not going to get decay as fast as the mouth breather will. So you have this imbalance. Yes, the 3 are related: mouth breathing, diet, oral hygiene. They're all related. However, I will give you my full opinion that it's the mouth breathing that is the driver of decay at any age. And meanwhile, nutrition and oral healthcare can play a role in it, certainly. But the big driver is going to be the mouth breathing. Yeah, crazy stuff that's out there. And it's all based on wonderful evidence. Part of the hiccup in the expansion is that we have these 2 pathways. Out there, there's nice research that shows when you expand, the nasal chamber size increases.
Sure.
So that's nice. But then the other stack of research won the day where it was, well, we did the early expander, but when we took it away, it relapsed. Well, certainly, if you're measuring the nasal chamber during expansion, if you give yourself like 4 millimeters of expansion, it'll show a difference in here. But if you take away that upper expander and let it collapse, you're back to where you started. So we have this like poor history of the research not being really studied well enough to know we probably should think a little differently about the amount we went. That's why I don't put an expander in a kid for under 8, because 3, 4, 6 millimeters, that's not going to be stable enough, but that doesn't allow me the tongue space in the lower. So I give them enough because I'm looking for the symptom list to go away. Just as much as I said I don't treat those things, what I do is I treat the malocclusion to a size where there are no symptoms. And so we don't stop until the bedwetting's gone. We don't stop until the behavior is gone, to the level now that we're far enough in 2 decades later. Yes, the kids get off the medication. So the kids who show up that are recommended to have medication for their behavioral components, which are real, they have these symptoms.
Sure.
We treat them first. They don't get the medication because then there are no symptoms to treat with medicine. The kids who come in on medications, and we've had them come in from 1 to 4 medications they're taking, when you have the right size and you get your breathing back and you get your sleeping back, when the symptoms fade, the medication can be weaned off. And the longer they're on it and the heavier the medication, the longer it takes to get off. You can't just stop those medicines. So we've seen some kids take 6 months to a year to kind of come off the medicine. But again, it's appropriate, and the medical community will do that. We don't take them off the medicine, of course. But when the symptoms are lower, they go back to the physician, they work down. And now when you're in 2 decades or more, you see these kids 5, 10 years later. And 5, 10 years, no medication, thriving. They're A students. They have no tutors. They go to the college they want. They're basically living their best life as opposed to struggling to keep up or be below average. It's unnecessary. So as much as I don't treat symptoms, boy, do they go away. And I base my numbers off of Bogue, McNamara, and anthropology research. I'm nowhere near pushing a child to what a normal human being would be. So my numbers are low at 40 when I'm told, oh my God, Dr. Miraglia is so aggressive. He's gonna break that child in half, or that's child abuse, those numbers. No, 40 is nowhere near 55. And 55 is an average human number. You get to 40, now you track my 2 decades, and I can tell you with these kids who were treated earlier, getting to the 18 to 24-year-old range, here now well over 50% of them have their wisdom teeth erupt. So my population of kids I treat has their wisdom teeth coming in. And I can tell you the delineation really, the earlier I treat, the better, because the bud didn't have a chance to form sideways.
Got it. Yep. Makes sense.
So take a look at your pans through the different years and you recognize, look, the kid who comes in at 10 and above, the moment you can pick up the bud, if the jaws were small, they're probably going to be rotated already. That I can't correct. So the older the child is, the more likely, well, you're going to get beautiful resolution of your symptoms. You're going to have better breathing. You're going to have 28 teeth. But I want to show you this little thing, this little turn.
So mesioangular, you're not going to,
your wisdom tooth's going to be flat and I can't fix that. So I would still tell you, you're highly likely to not fit your wisdom teeth. We're going to worry about that when you're older. But earlier you get the kid, the more likely when you give them the right size foundation, they can have so we have a really high rate of wisdom tooth eruption because we have a lot of people we treat from 3 to 7, 8. And the earlier they have the full foundation, one of the other benefits is getting in early 3 to 7. You know how many kids have an impacted canine? Then 0.
I say that all the time. I mean, I literally saw, if I got a patient young, impacted canines, other than, again, you every now and again get these horizontal up there, it's a malformed tooth. It's just not going to form properly. Again, it's a genetic issue with that specific tooth and its eruption mechanism. Outliers. There's always outliers for any of this stuff. But if you have just those typical sort of high mesial angulated canines that when you looked at, those things were going to be impacted, but they would otherwise developing normally as a tooth bud. You do, and that one thing I saw in the arch wires that I liked a lot is I got more expansion anteriorly too. I struggled with the turnkey expanders, and again, we'll get caught in the weeds on the technique of it, but the commonality is you've got to expand enough to get that anterior developed, because if you don't, you end up with this V shape, wider V, and they're still really narrow in that middle and anterior third. And your canines, I mean, there's not an orthodontist out there listening to this who hasn't had a situation, or a GP who does ortho, or pedo who does ortho, who hasn't had a situation where they expand these kids and the canines still get impacted. And they're listening to us saying, yeah, Mike and Ben, whatever, I expand all the time. It's either the amount you're doing or the technique you're using, because it used to happen to me too. When I was just doing it the way I was taught, only addressing the upper, big part of that is, as you alluded to before, they're probably not addressing the lower enough. And so your target is too narrow. You can't get enough upper expansion because they're like, Mike, I'll put him in Brody bite. Well, yeah, because your mandibular arch is narrow and collapsed. You've got to upright your lower, and then you can expand, get the correct amount of transverse development on the upper. And very long-winded explanation of what you said very well, which is the canine impaction rate is like none.
That's right. The earlier you work, the kids come in later and they're there on the x-ray. Okay, now I have to give you the right foundation, open that space and go bring in the tooth. Got to do it the hard way. So do it the early way. Then we had touched on earlier, when you give that right amount of width, if you do get enough width, your sagittal will correct. So my experience has been, and it is based on McNamara's nice research, getting the upper developed appropriately will help you with the forward release of the lower trapped jaw. So my numbers correspond beautifully with Bogue, McNamara, and the anthropology research to get to a point where I can correct the sagittal without elastics, because I'm not a big fan of elastics, because look, Newton's third law, pull forward means pull backward, So class 2 elastics, it's technically not pulling this forward only, it's pulling up or back. Those are retractive. I don't like to do anything retractive, so I want as much wider. And with McNamara's research, he also showed how a point travels forward with just lateral expansion. So enough lateral expansion and a point tracks forward. So you're getting your upper width gives you forward growth, thanks to McNamara's research, and the upper width with the lower width. If you have enough of upper, which that's why you need both, because you got to get the top 8, 10, 12 millimeters. When you get to 40 on top, or the 8 plus for the kids who are, at 36, when the top is correct, your lower sagittal will correct. You're going to lose the class 2. And that class 2 patient has both jaws going forward, but the lower more, because you have the release You got A and B point traveling forward. So basically in my world, thanks to the research, it shows, yes, appropriate expansion. The transverse solves the sagittal because the sagittal was a result of the transverse deficiency. I see it that way. When you're really narrow, you're trapped back. Your sagittal is secondary to that. Now look at it the other way. The kid comes in narrow because you can't really only be back and wide. I don't see, that's not how malocclusion works.
It's rare, yeah.
Yeah, very rare to be wide but all the way back.
Yep.
So when you're looking at a sagittal component, when you only address the sagittal, I mean, let's pull it forward. Well, pulling forward is helpful. I know you get more room for air, but you know what? Sagittal correction only does nothing for the width.
You have posterior crossbite at that point.
Well, and if you do pull both forward and you don't have a cross, you're still narrow. And the problem with sagittal only is it offers no benefit to the transverse. However, correcting the transverse almost always delivers the sagittal correction. So why not do it the easy way, meaning get your diagnosis right. You've got a transverse discrepancy here to focus on because like you mentioned in the open bite, vertical, correcting the transverse can solve sagittal and vertical. But if you go fight sagittal alone, you're getting no transverse improvement.
Oh,
if you
absolutely.
Vertical alone, you're getting no trend. So why fight the two that are the ones that are downstream of? I see sagittal and vertical discrepancies as a symptom of the transverse collapse.
Yeah, the transverse collapse. Like so.
And it's the easiest one to correct. It's the easiest
I
one
know.
to go after. And so many other things fall in place. Why are we fighting this the hard way? It seems so easy. If I learned how to do this and help kids like this, anyone, I mean, anybody can do this. And so for me to have picked it up, I just like to do it the simplest way possible to get the maximum benefit. And it's the transverse correction gives you the sagittal. I would never think to fight with sagittal because I know a sagittal correction only doesn't offer any benefit to transverse. Vertical, I would never try to fight vertical. You go for the transverse first, the other ones fall into place. It's been my experience, but I do base it off of what McNamara taught. I think the research is there.
What you just said, expanding, right? Addressing a transverse deficiency in a patient who has one. Why is that so controversial? Why is that something that the orthodontic profession is in large numbers opposed to? Why are there so many people coming out, especially from our institutions, academic institutions, saying that there's no need to treat these kids younger and do any of this? It would be the first part of that. And the second part is, what can we do to try to, because at the end of all of this, everything Ben and I are talking about is a kiddo and a patient. And we're doing this to help improve the quality of someone's life, because he and I have both seen this and how it plays out in your practice and in your hands. And I've talked about that many times on the show, just how amazing it is when you do this for someone. It's why I'm devoting the rest of my career to trying to get this message out there and teach it more. That being said, it's still not permeating our entire culture of our profession. So why do you think people are still so resistant to it? And then what can we do going forward to try to help our colleagues see just how valuable this can be?
Yeah, I think there are some reasons. It would be my opinion, but I can give them. I think that in the ortho specialty, there is a long history of having it as a tooth-focused approach.
Yes.
You know, the angle expansion people, they kind of lost the battle a long time ago. That argument was lost, and that tooth-focused approach took over. Like, we'll accept the foundation as its size. We're going to treat the teeth. So you have a tooth-focused approach. I think the second thing that happened was the research we were talking about on early treatment not being very stable or effective and collapsing. So there's no reason to do early. Meanwhile, we understand, well, it was primarily retainers and or upper expander only. That's not growth. So of course, there's nothing to show for that result there. Led to let's treat late. So my choices are focusing on the teeth, number one. Number two, treating later, like 11 or above. Number three, a sagittal focus. The sagittal became a focus. They got so fixated on correcting class 2 to 1 and 3 to 1, but really it's not being, 2 or 3 as your biggest issue. The width was the biggest problem, and it's the width that shows up in all the research, whether it's anthropology or malocclusion research, the width, but that's where the breathing issues are in narrow. Your phenotype for sleep disorder breathing, poor breathing, OSA, whatever it might be, is narrow. Because narrow is what takes your nose out. Narrow is what gives your tongue problem. Narrow gives you your back because you're trapped back. So it really is the width. And I think my short answer for why we haven't gotten anywhere is I think the 3 choices were made in the specialty to tooth-focused, sagittal approach, treat at 11. And I think when you're tooth-focused, sagittal approach, treat at 11, you're restricted to braces that kind of go straight back. The arch wires go straight back. We can line up these teeth going backwards. Braces don't offer wider or forward very much in the traditional model.
Right?
The twin bracket with the wires that go straight back.
Yep. Standard arch form, right?
Standard arch form, which is not any not a human being standard.
Not any standard I want to treat to.
Not a standard human being. But that doesn't offer wider or forward, so you're shuffling the teeth back like dominoes to fit in. And of course, there's a limit. That's when the extractions happen to get the crowding done. So I think it's teeth, sagittal, and late are my basic answer for where we're stuck in that. This is the educational pattern. If these are our focuses, then what are our tools that do that? And so teeth, sagittal, late, that's standard pro forma wires that go straight back. And you have a limit to what you can do. So you extract, and then you have a pathway of having your tools match what you're diagnosing. And if you're diagnosing teeth, late, and sagittal, you better have tools to do that. And that doesn't equal an expander early. So it's a
interesting.
Right. That's my opinion.
I like that. I like that explanation.
How do we help it? Well, we teach GPs. I teach a lot of GPs. I mean, I've had the good fortune of having a couple of orthos come through and appreciate what I'm doing. And I enjoy that too. But GP is very open to what I teach. I've trained over 500 offices to offer early treatment to kids. Teaching GPs, teaching pediatric dentists who are obviously tooth focused because they handle a lot of children with decay and help them. But in the pediatric dentistry model, doing less early intervention with expanders and kind of growth appliances. So teaching pediatric dentists helps. And my third category that we're jumping into a little bit more heavily now is educating the parents directly.
I was hoping to say
reaching out and educating. Look, social media can be wonderful in any direction. It can be good. It could be used for good or bad. But now that I have 2 decades and I feel comfortable with what I've done in my own community and then teaching other people to do it, I feel very good and comfortable about spreading the message and teaching parents that you have alternative to extraction. You don't have to agree to that. It's okay to say no, thank you to a procedure and say no to extractions. It's okay. I give parents permission. Go get another opinion. Go get another opinion. So I'm starting to teach the moms primarily pay a lot of attention to their kids that you have alternatives out there. You just got to look because we're not everywhere yet. And if you do keep looking around, you're going to find people like you or me or others, and they're out there. We're out there. So I'm starting to teach the parents that you should be careful when you hear things like that's normal. Wait till later. You'll outgrow it. No, not necessarily. And you also should look for other opinions when you hear about extracting teeth. That's also trouble. And so, the one of the things I would bring back onto the table real quick to mention, I know I've tried to make this, I was going to make this point earlier. I missed it, but in that I have the experience in my 20 years of seeing the kids who have come in as an opinion to me because they've been told they should have extractions. And it turns out overwhelmingly, the kids who show up as an opinion because they didn't want to have the extraction, so they go looking around, they find me. Overwhelmingly, they did have an upper only expander by the office that told them they're going to take out the teeth next. Because now I get the words from the parents like, well, so teach me about how you went. Well, when they were 8, they said, you're crowded, you're narrow, you got to have an upper expander. We did it. We did everything they said. And then now that we're 11, they said, well, we did everything we could. And that all of that we did wasn't enough. It still adds up to taking the teeth out. I'm like, but I thought we did this to avoid that. And I said, yes, we did everything we could. But here's the tragedy. The parent who wants to know a little more and they're entitled to it, they'll get their records. And when I get the records of the model, and the pre-treatment model is the measurement between 3 and 14 at age 8, right? And let's say it measures 30. Guess what the child is measuring in my chair, and they've had an upper expander? 30.
Much more than that,
30. So my 20 years has been in the category of if a child shows up in my office for consultation about extractions being recommended, most of the time they had an upper expander already. And most of the time when that model comes in, they're the same measurement they are today that they were then. But again, it follows the research. This is not anecdotal. The research said an upper only expander was going to be successful and go back. And so I'm seeing that. But crazy thing is when you start talking to people who've had the 4 buys out, whether they're teens or adults, because those come in too. The teens and adults, it turns out it's an overwhelming majority that in my own practice, again, this is not research, but in my own practice, we ask the questions. Any chance you had an expander as a child? And the answer is yes. So the 4 bicuspid extraction, it turns out in my office, it's preceded with an upper expander. So it does follow the research exactly. There's nothing to gain from it. And even using it early, you're going to get, so
I
Yeah,
used to see those exact same
oh,
cases come to me
you
who had an
you have
expander. So with someone else in town, and it was an upper expander, and they come in and they said, we
yeah
went through this expansion. We thought it was going to prevent teeth needing to be taken out. We thought it was going to solve the
yeah
problem. And now they're telling us they need 4 teeth taken out and then canines are impacted. And I saw it actually in one of my courses. I go into some sample cases of that presented at that point.
right
And in none of those cases did they address the lower. And I think that's the thing that the people who
yeah
are the lay persons listening to this are probably thinking, I don't understand. Why would they not address the lower? It's just dogma within the orthodontic arena. And I think
yeah.
that's why you're finding more success within the
It's a
GPs.
protocol and a myth. They're
Exactly.
taught
I
you
mean,
can't do anything to the lower. That's too bad because it's unfortunate we're trapped then. But meanwhile, we're going to take that child, and you know what you're going to do to that child and what I'm going to do to that child.
Yep.
No extractions. We're going to grow the jaws. You're going to
Yep.
keep all your teeth. And then what's more than that? I have a shot at your wisdom teeth.
Yep.
I got a shot at your wisdom teeth. And so symptoms will fade away. They'll get their treatment. We've never met a child where they were told to take out the teeth and they had to do that in our office.
Mm-hmm.
And we have a beautiful amount of material, and I teach it. I don't hide it. I teach it. I'm out there showing it. I teach it. Whoever wants to learn it, I'm happy to share it. Children should be treated differently today. It should be early.
Mm-hmm.
It should be transverse focused,
mm-hmm.
and it should be foundational. You know, you really got to go at these kids earlier. And we treat malocclusion. I treat in my lane.
Yep. You did a really nice job encapsulating, and what you said and what we said is going to push a lot of people's limits on what they're comfortable even hearing, but that's okay. That's good. That needs to happen. We have to start having these. That's how growth and progress happens. I am all about breaking free from dogmas, and you have to, for the sake of these patients and the kids, just take your tooth straightening. This is what I'm trained to do, hat off, and put this is my kid and this is what they present with. And I want them to have the best outcome. What parent wouldn't want their child's growth normalized if they had the choice? And Stacey Becker uses a great analogy where she talks about, I think she said she got it from someone too, but about the eyeglasses, eyeglasses young. I mean, what parent would say like, yeah, I know my kid can't see, but all that sort of stuff. Like, I really don't want to deal with that until they're older. So we don't have to do as much over these next years. Parents want their kids to thrive in every way possible.
Yeah.
If you could normalize that. And
they're unhealthy. They're unhealthy now. So you treat it now.
Right.
And an unhealthy child does not outgrow any of this. None of it's normal. Don't outgrow it. They're not going to be a healthy adult when you're an unhealthy child because it's due to the breathing and sleeping.
Yes.
That doesn't feel correct. And it just kind of changes forms in the symptoms. But you're going to grow up to be an unhealthy adult, medicated for your symptoms.
Yep.
Maybe one day you'll get a CPAP, maybe you won't.
Right.
But you don't necessarily have to have OSA to be a very unhealthy adult. You can be shy of OSA numbers.
Yep.
And you're wildly unhealthy, suffering.
Still be unhealthy.
Yeah, it's terrible.
Point. Well, how do people get in touch with you if they want to reach out to you, contact you, learn more from you?
Yeah, the best contact is to visit the Airway Health Solutions website because it's not only where we have contact information, we offer coursework, but you can also reach out and email us directly there. So www.airwayhealthsolutions.com. That's a great place to kind of learn more or continue a conversation. I'm happy to help anybody help a child.
So great. I'll put that in the show notes as well. And I just can't thank you enough for being on the show and taking the time. I mean, I went longer than I usually do, but I just wanted to, there's just so much good information there. And I love talking to you. And like I said at the beginning, kind of geeking out on this and just letting people, one of the best parts about this platform is it lets people hear a conversation like this that you and I probably, I mean, we talked about a lot of things that we did to talk about or brainstormed on back and forth, but people don't get to hear it. And the podcast platform, people get to hear someone like yourself, someone like me, who actually come at this from sort of, you come at it as GP, I come at it as an orthodontist, but a very almost similar evolution in how this got to be a thing for each of us in our practices. And the one thing that no one can deny is that we see this in our patients, and it's allowed us to change so many patients' lives. And that created and burned a passion that burns within both of us that you can't put out. And I refuse to let that be put out until more people start to understand that this is real. And parents out there, push your providers. Don't settle for them to tell you that you can't get growth young to help your kiddo thrive.
Absolutely. Yep. Yeah, it was my pleasure to be on. Thank you for having me. I have a feeling you and I will have more conversations.
Absolutely. Dr. Ben Miraglia, thanks so much. I can't tell you how much I appreciate this, and I look forward to following up with you and continuing on from here.
Absolutely. My pleasure.
Right. Have a great one. All right, take care. Bye.
Take care.
Thank you for watching this episode of the Doc Podcast. Be sure to visit theorthocoach.com to get access to ADA CERP recognized CE courses or to schedule a private one-on-one coaching session with me. And remember to join the Doc community on Facebook for more great content designed to help you succeed both personally and professionally. Just go to Facebook, search for the Doc community, and request admission into the group. You can also find Doc on Instagram at @theorthocoach. And always remember, you have been blessed with the ability to do amazing things.